Dr. Elizabeth Seo, Lisa to her friends, is a board-certified internist working as chair of physician engagement and women's health at Cooper in Camden, is an assistant division chair in the internal medicine residency program, and is the director of climate health and director of medical humanities at Cooper. She graduated from Robert Wood Johnson Medical School in New Brunswick and did internal medicine training at University Pennsylvania Health. She must be an expert Debussy player because she mastered both the piano and French. Is that true? Her lecture is entitled Climate Change, an Evolving Threat. Dr. Seseo, the floor and screen are yours.
Thank you so very much for the gracious introduction. There's so much to cover in a topic like this, and I'm going to, by necessity, keep the comments focused on what I think are some of the greatest threats to human health, and especially proximate to the summer coming upon us. We'll be talking about heat and air pollution and other environmental toxins, including plastics. And so we'll do a deep dive on some of those and hopefully be able to relate it to clinical practice so that you get some clinical pearls that you can apply to your practice, whether it's inpatient or outpatient. I do just want to acknowledge, out of reverence for history, people in place, that we're speaking from the ancestral land of the Lenni Lenape people, and offer thanks for the stewardship of this unceded land throughout the generations. So this infographic was taken from the CDC. It's unfortunately no longer on any government website, but I think it really nicely elucidates the depth and the breadth of climate health impacts. And even this is not all encompassing. It doesn't necessarily get to some of the associations with dementia and Parkinson's disease. It doesn't necessarily hit things like cancers and malignancies. But you can see just how wide-ranging some of these impacts are. And so what we've been dealing with for generations, really, for 60, 70 years, have been issues with misinformation and disinformation. We saw this with tobacco smoke back in the 1950s, with concerted campaigns around sowing doubt and misinformation. And we see this again now with the fossil fuel industry. And similarly, it took a while for physicians to realize that there were health impacts from smoking. And I think now we're beginning to understand that not only the concentrated pollution that you get with a cigarette, but the diffuse pollution that we breathe in every day can have health harms. And if you think that because you live in a nice suburb that you might be unscathed from this, the State of the Air report just came out from the American Lung Association, and New Jersey does not fare so great. And the World Health Organization posits that about 98% of the population breathes unhealthy air because there's never been documented a safe level of particulate matter to breathe in. So again, even if you are in a posh suburb or if you're in an urban center, you're going to be experiencing climate and environmental risks. But certainly we know that there are some individuals that experience harm first and worst, and that's the climate gap. Those are the people that may be living next to a highway, that are living near industrial sites, or in PA, there's a lot of issues with fracking and people living proximate to those sites. So we have these areas which are actually called sacrifice zones. It's a very deliberate because we know that there are health harms induced from environmental toxins. So now the things that we're going to focus on in particular, and I'm going to try to put a pearl in front of those things that I particularly want you to pay attention to. I'd love everyone to remember everything, but if there's a pearl, I specifically want you to pay attention to that part. So these are the 5 areas that we're going to do some deep dives on. And the first is around climate communication, because I think historically, we in the medical field have not necessarily done a good job amplifying the issue. We tend to people in general tend to think about climate issues in terms of plants, penguins, and polar bears, and not in terms of human health. But the climate crisis is first and foremost a health crisis, and that's how we really need to be thinking about it. So this was a study done by John Kocher. He's actually going to be taking over the George Mason School for Climate Change Communication, which does a lot of work on this. This was a multinational survey of health professionals from 6 different WHO regions, and I know there's a lot of detail here. But a lot of the crux of this is, not surprisingly, and very similar to other studies, many health professionals understood that this was a big issue, but they noted these barriers. First and foremost, time, not surprising, but also not having the knowledge, not having the continuing education or the communication training around how to deliver these messages. What is the actionable thing that the patients can do? And there's been some fascinating follow-up studies on this. Maybe a conversation for another day. If you just look within the medical profession, the National Medical Association, up to 93% of their physicians think it's important to be reducing the impacts of climate change because of impacts on human health. ATS, about 90% have concluded that climate change is happening, and the great majority see that it's happening with their patients, whether it's related to increasing allergens, because that happens with climate change, with higher CO2 concentrations. There's more of the pollen produced and more of the allergenic components, particularly the AMB1 protein that gets produced from wildfires, from severe weather events displacing patients. So these are effects that have already been noted. Now I have a pearl here because this is from the Six Americas study, and the Six Americas has been done year over year, and what we see is that more and more people are moving to the alarmed, concerned, and cautious categories. But we see at the same time the doubtful and dismissive are not really changing that much. And what that tells us, though, is that about 3/4 of the U.S. population is open to this. They want to hear this information, and really just the small minority, you may not be able to move the needle, but that doesn't mean that we don't bring it up and we don't talk about it. This was really interesting. This is from the Yale Center for Climate Change Communication, and you can see the percent difference in terms of how many people think global warming is happening. You can see that it's more in our area in the Northeast, and not surprisingly, you can see other areas of the country where there are differing opinions among the populace. Now, if you look specifically within adolescents and young adults, again, not surprisingly, about 85% endorse being at least moderately worried. And in younger people, this is across the political spectrum. So whether you're Democrat or Republican, they're experiencing at least moderate distress related to climate change. Now, in this study, the climate change in the American mind, this came out just a couple weeks after the election. It came out mid-December. And what they showed was that compared to 10 years before when they ran this, that 8 percentage points more Americans felt that their health was being harmed. So it was not looking at just, is climate change happening? This is not just, is it impacting the polar bears? This was that 40% of Americans now recognize that their health or the health of people that they love could be harmed by climate change. And as we're trying to deliver this message, and I know that this is a little bit of a busy slide, but it's incredibly important because they surveyed from liberal Democrats to conservative Republicans, and across the board, you can see that your primary care doctor was among the most trusted. And I know it looks like it's a little bit less with liberal Democrats, but that's just because the level of trust among liberal Democrats was much higher overall. But for very conservative Republicans, after family and friends, your primary care doctor was the most trusted messenger. So we really do have a place in delivering these messages and citing that this is for our patients' health. So next pearl that we're going to turn to here. And again, we're on the heels of summer. I know it doesn't feel like it right now in New Jersey, but certainly we know with increasing energy in the atmosphere that we see more climate derangements and more unusual type of climate events. And certainly, 50 degrees in almost the Memorial Day weekend is abnormal. So this is from Climate Central, which is in Princeton, New Jersey. It's called Warming Stripes, and it kind of looks like modern art. I have this hanging in my office. If you look just nearby us, New Jersey, Delaware, you can see that New Jersey is actually warming faster than the rest of the continental U.S. There's a lot more red on there. And there's some, complex climatologic and geologic reasons for it. Some of it has to do with there's an AMOC current, this oscillating current over the Atlantic. Some of it has to do with the fact that we are about 17% impervious surfaces. So, New Jersey has a lot of parking lots and construction sites. And but all of this goes into New Jersey being really hot. And so as we're coming on to summer, we need to be particularly aware because that first heat wave of the season tends to be the most severe for people's health because we're not acclimatized to it. In that the Northeast, we actually have about a 4.39% higher rate of mortality compared to the rest of the US because we have relatively cold winters. And then we go into these, 90, 100 degree summers. And so our bodies just aren't acclimatized to it. And it can take 7 to 14 days to acclimate. And so that's where we see a lot of increased hospitalizations and mortality. But there's a wide range of heat-related illness. Some of the problem among physicians is that we have to keep an open mind and we can't just limit ourselves to thinking about heat-related illness because there's actually a wide spectrum beyond this. Although certainly heat injury and heat stroke is where we become very, very concerned. Many of us, I'm sure, have experienced heat exhaustion, the headaches, the nausea when you're out in the heat too much. Heat injury is where you start to have multi-organ dysfunction, but usually you don't have a core temperature elevation and your mentation is intact. Heat stroke, which can have a 20, sometimes up to an 80% mortality, depending on the clinical series, is where you have core body temperature elevation, usually greater than 40 degrees Celsius, and you have abnormalities in the CNS. And this is I know a busy slide, but there's a lot of very complex pathophysiology that medical students actually really get excited to learn about because this is not part of the traditional curriculum. I teach our medical students about this, but we have the sweating end of things, which from an evolutionary perspective actually allowed us to chase down the prey on the savannah and be successful as a species. But when that sweating mechanism is expired, then we have major issues because we hit hydromyosis. That's where you lose the ability to sweat. And then you're completely dependent on vasodilation. And so when you are purely just vasodilating, as you can imagine, you're diverting that blood flow away from other organs that need it. So it's being diverted away from the gut. So you can see things like GI bleeding. It's being diverted away from the heart, away from the kidneys. And so you can see cardiovascular injuries, LFT abnormalities. And so there's a lot of really complex physiologic things that are happening. Some of that problem with the diversion of blood flow from the splanchnic circulation is that endotoxemia can result. And so people can look when they present to the ER as if they're septic. And they can actually have leukocytosis up to 30, 40,000 and be treated just, as with a SIRS protocol as if they are septic. And so, a lot of things can be going on and these people are very, very ill, as I alluded to. They do have increased oxygen consumption, increased metabolic rate. The heat shock proteins is thought to be one of the mechanisms, as well as systemic inflammation that really drives some of these changes. And heat shock proteins are also implemented or implicated rather in some of the adverse birth outcomes that result depending on when pregnant women are exposed to heat. We spoke about the GI ischemia. And most people who present with heat injury or heat stroke are going to have some transaminase elevations, but also the neural tissue and the vascular endothelium are very, very temperature sensitive. And we can only thermoregulate up to a point. So once you get to be above a core temperature of 108 degrees Fahrenheit, oxidative phosphorylation actually becomes uncoupled and many of the enzymes cease to function. And that's just from a pure physiologic standpoint. As I was alluding to about acclimatization, this goes into a little bit more detail with that. So people who live in Phoenix, granted, they have access to a lot of air conditioning, but in general, they have plasma volume expansion. They divert more blood to the periphery and they're vasodilating more so that they're cooling that blood better. They have a lower threshold for sweating. And when they do sweat, the sweat's actually different. There's less lactate and less salt that comes out in it. So all of these physiologic adaptations, we in the Northeast, in New Jersey, don't necessarily have the benefit of in May, June, even July. And as I alluded to with the climate gap, while heat is uncomfortable for everyone, there are certainly going to be more people at risk. So we need to be asking people about occupations. In New Jersey, it's not just the construction workers and the people who are working on the lawns that are at risk. Actually, people who are restaurant workers are at some of the highest risk because we don't have heat worker protection programs, and a lot of the mom and pop restaurants don't really have good protections in place. We need to be asking our patients about their housing status and if they have access to cooling and if they have the money to turn on the electricity, because you can have an air conditioner and not be able to turn it on. And then, of course, there's the individual susceptibility. Many of our patients who are on medications and have comorbidities are going to be very at risk. So I really like to bring up this study because I know that tip of the iceberg is maybe not the right analogy for this, but this was a study looking back retrospectively. It was published in Nature Medicine for a really dangerous heat wave that happened in Europe a couple years ago. And in the news, it was reported at the time that there were about 8 to 10,000 deaths, which is terrible. When they actually did this and they looked at the observed to expected, they actually put the number at around 70,000. First they said 61,000 about, and then they re-evaluated it. It's over 70,000 excess deaths that occurred from heat. And so, you might say, well, why is there this huge discrepancy? And it gets to that fact that that little tiny red box at the bottom, about 10% of the illnesses that we're picking up are coded as heat-related illness. All of these other factors, though, are driving people to the ER and driving people to the hospital, and they're not being recognized by us as heat-related illness. So they're coming in with MIs, with strokes, with heart failure. We even see more nosocomial infections, more sepsis, definitely more mental health disease, more schizophrenia. And actually, our patients with schizophrenia have the highest rate of death in the setting of extreme heat. Some of that is behavioral, but some of it is related to the side effects of the antipsychotic medicines that they take. And substance abuse that we see, whether it's in Phoenix, Arizona, or New York, there is across the board increased mortality and increased overdose deaths from substance abuse. And some of that is that, there's mental health, there's stress, that there's people are maybe trying to self-soothe a little bit and use more substances. But then some of it is also the pathophysiology of using stimulants, using opiates that affect thermoregulation and dehydration, which may potentiate some of these medications. So a lot of complex things, but we as physicians, we need to be more aware of this as we see it coming into our practice. And we need to be counseling our patients more frequently on the side effects of medications because many medications that we give are going to impact our patient's ability to respond to extreme heat. So, if you're thinking about the patients with heart failure who are on diuretics and, they're used to fluid restricting, well, what are you going to tell them when it's 104 degrees out? And they're still fluid restricting and they're still taking their, 80 of Lasix. So we need to really tailor these plans. Maybe we need to be telling people to be weighing themselves more frequently, maybe liberalize fluid intake a little bit, but it needs to be tailored because unfortunately at this point, we don't have the randomized controlled trials to say definitively, what is the best practice for these patients when people are on beta blockers, which can decrease sweating and affect thermoregulation, when they're on vasodilating agents and nitrates, calcium channel blockers. We don't really know what the best thing to tell these patients are. We also need to be thinking, though, about the effects on the medicines themselves because, and there's a pearl here too. So we need to be remembering that if people are getting medicine shipped out from insurance companies and they're sitting out in the sun with a 90-day supply of Synthroid, well, it might be inactivated. If there's an EpiPen that people keep in the car, inside cars, it can get to be 170 degrees Fahrenheit. And so they can be inactivated. There's actually an insert warning that the albuterol canister can explode over 120 degrees Fahrenheit. And even if it doesn't explode, you'll just have less medications delivered per actuation. So, if someone's having an asthma attack, and as we said, respiratory conditions are one of the things that can worsen in the heat, and their albuterol isn't working properly, that's when they end up in the ER. As I mentioned, we need to be counseling with a lot of these other substances, these other things that people may be taking, and also over the counters as well, remembering all those anticholinergic side effects. I always have to remind myself of this mnemonic, which I guess makes it not the best mnemonic, but another really interesting series of studies that have been done are with sugary drinks and CKDU. CKDU was also called Mesoamerican nephropathy because it was first identified in sugarcane workers in Central America. And these sugarcane workers would go out into the field, not be drinking water for 10, 12 hours, be working all day, and then they would report feeling like they were peeing out sand. And when they checked them, they had high levels of urate crystals. They had elevations in their creatinine every day when they came home from work. And then it would go back to normal, and then it would happen again until gradually, creatinine started to increase. And so you end up with this CKD it was called of unknown origin, but now we kind of know what it's from. But interestingly, when people take sugary drinks, it increases this whole cascade of inflammation, partially through the fructokinase mediated cycles. And so just decreasing energy drinks and other sugary drinks when people are rehydrating can sometimes help to mitigate some of these side effects. And it's not just heat exposure that's certainly the biggest part of it. There have been thoughts that maybe some of this is pesticides, heavy metal, silica, maybe also some endogenous agents that are in there, but a lot of it is really from the rhabdo, the increased core temperature, and the dehydration and crystalluria that results. Now, with heat-related illness, how are we going to treat it? Because that's really critical. Because if someone presents with heat stroke, we literally have minutes. It's just like we talk about with stroke. Minutes are brain. It's the same type of thing with heat. We need to act very, very quickly and get that core temperature down very quickly. So another pearl here. Cold water immersion is really the gold standard. And out in Phoenix, EMS has this down to a science because they go out with body bags with ice water and ice, and they put people in it immediately. If you don't have that, then doing an ice and wet towel rotation, especially through the axilla, neck, groin area, that can help. If they're intubated, you can apply ice packs. If you're awake, it's not very well tolerated. People don't like to have ice packs near their groin. But there was an interesting study with athletes that you can apply ice packs to the glabrous surfaces. So cheeks, palms, soles, and that was actually very, very effective and much better tolerated, as you can imagine. There was even a case report of intranasal cooling in an elderly man. So once you get the temperature down to about 101, 102, then you can start to think about all your secondary analysis and managing complications. Even though, we'll do things like chilled IV fluid, cooling blankets. There's little evidence to guide it. One thing we definitely know is to not do alcohol sponge baths because you're maximally peripherally vasodilated, and so you can end up with increased absorption. And as uncomfortable as that looks, it really is the gold standard to get people into ice baths, but they should be monitored with a rectal thermistor. If you're not able to get a rectal temperature, then for most people, cooling for about 15 to 20 minutes will drop the temperature about 3 degrees Celsius, approximately, or until they start to shiver. Mental status is really important that we're keeping close tabs on that because that can change so frequently. So the recommendation is really every 15 minutes to be monitoring that. And muscle compartments. Even though, it's not very often that we see malignant hyperthermia or neuroleptic malignant syndrome, you can differentiate because those latter two conditions will have rigidity, whereas you should have flaccid muscles if someone's presenting with heat stroke. And as I mentioned, GI bleeding is going to be a risk because of diverting all of that splanchnic blood flow. So you need to look for GI bleeding and treat accordingly. We talked about the SIRS protocols. You're going to be fluid resuscitating them, dealing with electrolyte abnormalities, but you also need to be keeping a close eye on cardiac issues because many will have cardiac ischemia. Sometimes there can be arrhythmias. It's often very hard to control the arrhythmias unless the body temperature starts to get into a slightly more normal range, like around 101 degrees Fahrenheit. If people do start shivering, you can potentially think about doing short-acting benzodiazepines, or even neuromuscular blockade. Importantly, you should be avoiding things like Tylenol or aspirin because this is not a fever. You don't have a changed hypothalamic set point. And salicylates in particular can contribute to the hyperthermia because it also uncouples the oxidative phosphorylation cycle. To recall back to medical school learning that. And then, of course, preventing heat. Obviously, we don't want people coming into our health system with these issues. So we need to try to stay on top of this with public messaging, with individual messaging within our practices, talking about work exposure, making sure that people have access to air conditioning. I know that New Jersey has an 1115 Medicaid waiver around housing factors. So that can potentially help some of these vulnerable patients. Making sure our patients know about cooling centers. There is in where I treat patients, for some people, the closest cooling center was the police station. And patients don't feel comfortable necessarily going there. And so if you go to nj211.org, you can find a lot of these other cooling centers and splash pads and parks and things like that. Importantly, don't just rely on fans because above 90 degrees Fahrenheit, fans do not help you. And in fact, it might make things worse because you end up with this like little area of cooling just above your skin as you have evaporative cooling from sweat. But if you turn on a fan, it takes that away and kind of turns things into a convection stove. So you might want to counsel patients against that. And then things like, avoiding hot, heavy meals and alcohol. I usually, in the summer months, counsel my patients to download the OSHA NIOSH app. So they can look every morning, see what is the heat going to be, when is it in the danger zone for them. I also tell them to download the airnow.gov app because it will tell them about the air quality. And often the air quality and the heat go hand in hand because as it gets hotter, there's more ozone production that just through a chemical process. We should also be using the CDC's chilled out mnemonic. Another pearl here. So these are just a few questions that we should be asking our patients related to what medications they're taking, if they have stable housing, their social isolation. We saw from the 1995 Chicago heat wave, the biggest risk factor for death was being socially isolated. So these elderly people with no one checking on them. So these are all questions that we can potentially be asking. And then there's tip sheets. So as we develop action plans for our patients with asthma, we can do the same exact thing with heat. And the last time I checked, all of these toolkits were still available on the CDC's website. We can also be publicizing in our offices and our practices. This is a really nice infographic from the Lancet. It goes through some of those things that people can do to stay cool. But we need to be doing this not just in silos. We need to be doing it with public health teams in coordination with government, and even thinking more broadly about resilience planning. If the electrical grid is stressed and we have blackouts or brownouts, that can have huge public health consequences for our patients. This is just another infographic from CDC. Now, the Heat and Health Tracker has been very, very helpful. My understanding is that it's probably going to be taken offline in the near future, but there are many states that are starting to develop their own more specific heat warning systems. So California just launched the Cal Heat Score, which gives risk down to the zip code level. And there's a lot of interest in that, especially in the Northeast. And we should also celebrate those areas that New Jersey's doing well with. So there's a heat hub, which is in coordination with the DEP and the DOH. And we have an interagency council on climate resilience, which is led by the DEP and with 26 different agencies throughout New Jersey government. And so this kind of high-level coordination is really, really important. This just gets at that. This was from last season, from last summer. This was a really interesting study looking at what would actually happen if those blackouts or brownouts happen in different cities. So in Phoenix, when they modeled this of power going out and then over the next 3 days gradually coming back online, they estimated that half the population would need to seek medical services emergently. And of course, that would completely overwhelm the health systems, and about 13,000 people would die. They did similar modeling for Atlanta and Detroit. You can see that the numbers here, in New Jersey, we're probably a little bit more similar to Detroit, also in terms of elderly and poverty. So you can see, certainly nothing that we ever want to have to test. Next, Pearl, is going to be around air pollution. Now, this is from the UK. So Ella had died when she was 9 of asthma, but she had been admitted 27 times over a 3-year period. And her mother said after she died that at no point over those 3 years was it ever told to her that air pollution could be making her symptoms worse. And so after she died, they reopened the investigation, and hers was the first time ever that air pollution exposure was assigned as a cause of death, as a medical cause of death. Now, of course, this is in the UK, not in the US, but certainly not the first time that someone has died of excessive air pollution exposure. And there's a big pearl here because I really want you to remember this study. I don't think this and similar studies to it have gotten enough press. This is from the Global Burden of Disease study, which is just a massive series of studies, really, that's out of the Institute for Health Metrics and Evaluation and the University of Washington. And this is over 204 countries. They get tons and tons of studies out of this. But in this one in particular, they were looking at particulate matter air pollution, and they found that it was the leading contributor to the global burden of disease, which means that it outpaces hypertension and smoking and diabetes and obesity and all of these other risk factors that we know are bad for people's health. But particulate matter air pollution outstrips everything else. And many of these other studies, when you see risk factors weighted, they often don't include particulate matter air pollution. So, it's not on everyone's radar. Looked at in another way, that this is a study in New England Journal. They looked at 61 million Medicare beneficiaries, and you can see that there is a near linear association with PM 2.5, those very, very tiny particles, and ozone and the mortality rate. And it's rare that you see slides like this, graphs like this, with that kind of near linear association in mortality. So the criteria air pollutants that have been laid out from the EPA are these on the side, and certainly everyone knows that lead and carbon monoxide are not good, but you might not have previously thought about nitrogen dioxide or ozone as being in the same category of severity. So we're going to talk about ozone briefly. You can see on the bronchoscopy on the right, that's a bronch after exposure to ozone. And as you can imagine, it looks red, nasty, inflamed. When they look at the BAL fluid, there's an influx of proteins because of the inflammation. There's decreased activity of the macrophages, increased leukocytes, all of these markers of inflammation. And the problem with ozone and the summer is that when you have fossil fuel combustion, it releases volatile organic compounds, oxides of nitrogen, but then they get activated in the presence of sunlight and heat. And so the ozone just gets worse and worse as the day goes on. So often, in the mid-late afternoon, ozone concentrations can be really, really high. And there have been some really elegant studies out of the UK. A colleague of mine in Scotland does a lot of research on this, showing that, we'll often get these average daily readings, but actually the rush hour, the morning, and then like the late afternoon, the air quality can just be horrific. And then it's kind of not as bad when people aren't driving as much in the middle of the day. But we really need to be concerned when, there are those peak episodes of poor air quality. So some of the health effects of ozone, as you can imagine, a lot of people will experience respiratory difficulties, cough, irritation, even headaches. But as I mentioned before, it's a cause for all-cause circulatory and pulmonary mortality. Also been associated with preterm birth, decreased reproductive health, and cognitive decline. And for some of these there have been studies with ozone and particulate matter that even when it's in the high end of normal, people like you and me who are doing cognitive tests can do worse than when there's better air quality. So looking at PM 2.5, and this graphic on the bottom gives you a sense of just how tiny it is. That's the size of a human hair. And you can see dust is like those little blue circles. And then just a quarter of that is the PM 2.5. There's even ultrafine particulate matter, which often results from traffic combustion, and that seems to be especially bad for us. But from when I first made this slide, I've been having to move things over to the definite side more and more. So we've known for a long time about the mortality, the cardiovascular events, the lung issues, cancer, asthma. Now we actually know that there's a really nice JAMA Network open paper on this. There's now an association with diabetes, hypertension, chronic kidney disease, and dementia. So as a hospitalist, this is pretty much every single patient that I'm treating, and all of these conditions are impacted. And there's some really interesting modeling about what those effects look like. Many of the common pathways, though, come down to oxidative stress and inflammation. There is a component of change to the mitochondria and mutagenicity, but just focusing on that inflammation is, I think, makes a lot of the things then make sense. So we're just going to touch on a couple case examples here of how that inflammation from particulate matter plays out. So with diabetes, air pollution has been shown to contribute to over 3 million cases of diabetes and about 14% of all disability-adjusted life years lost due to diabetes. And I know this is kind of like a complicated diagram here, but if you just focus on the bottom part of it, all of that inflammation and oxidative stress leads to some common adverse outcomes. In the liver, it leads to gluconeogenesis and lipid deposition, leading to MASH and MAFLD. The slide has to be updated, doesn't reflect the best nomenclature. It affects the white adipose tissue, increasing inflammation and increasing the white adipose tissue and decreasing the functioning of the brown adipose tissue because of altered mitochondrial function. So, and that's your good metabolically active adipose tissue. And then at the skeletal muscle level, leading to insulin resistance. And in lab animals, there's also been demonstration of DNA changes, epigenetic changes. Now, with cardiovascular disease, when people think about air pollution, they often think first about the lungs, but actually the cardiovascular system is the most impacted by PM 2.5 air pollution. And this is a really nice paper if people are interested from the New England Journal. My colleague Karen Solomon started a specific subsection of the journal, fossil fuel and health. So I would certainly direct people to that series if you're interested in learning more about it. But not only does it accelerate atherosclerosis, the pulmonary reflexes that get activated when breathing in these particles will trigger the autonomic nervous system. And so there's an association with arrhythmias. And actually, my colleagues and I just completed a systematic review on this with atrial fibrillation. And as I mentioned, cardiovascular deaths form the lion's share of the pollution-related deaths. So as you can see here, about 2/3 of the cases are from ischemic heart disease and stroke. And certainly pulmonary and cancers form a sizable piece as well. But when we think about all of our patients we're treating with cardiovascular disease, how often do we counsel them about looking at what the air quality is, or about, wearing masks when the air quality is bad, or getting filters for their homes? These are all things that should be part of our armamentarium. With lung cancer, there's a ton written about it, and it's interesting because it's been increasing by about 30% at the same time that smoking's been decreasing. And the IARC has called PM 2.5 a Group 1 carcinogen. Back in March, the IARC also called gasoline a type 1 carcinogen because it's associated with bladder cancer and also with AML. There's also some thoughts that gasoline is associated with slightly, it's not the highest quality evidence, but also with ALL, myelodysplastic syndrome, multiple myeloma, couple other syndromes, conditions as well. So in this study, this was by Charlie Swenton's group in the UK. They looked to see what exactly was the pathogenesis of PM 2.5 and lung cancer. And what they found was that when there was a breath of PM 2.5 that resulted in inflammation with an influx of macrophages, an inflammatory milieu. And what happened was that it allowed the proliferation of these already abnormal cells, these EGFR mutant lung epithelial cells, and they then flourished into a lung adenocarcinoma, which we know is the type of lung cancer less associated with smoking. So here, and this study caused a lot of commotion because you see that pathophysiologic connection then, so that it's not just a correlation or an association. You see how the pathophys actually backs it up. For people who might not be as swayed by the science, there's also our health economist friends that can help us calculate damages and attributable costs. And so here you can see the annual cost attributed to air pollution for not only just healthcare usage, but also the days lost working and in school and benefits paid. Now, the good news, of course, is that if air quality improves, you can see a rapid improvement in symptoms. In these 3 studies that I included, although there's many more, symptoms improve and pulmonary function tests also improve very, very quickly when you remove an individual from a polluted environment. And this was an in situ version of this. So when they were holding the Summer Olympics in Atlanta, they did the study where they cordoned off the traffic, and so the ozone improved by about 30% or so. And about 40%, there was a 40% decrease in asthma admissions for both children and adults, Medicaid and other insurances. And then, of course, after the Olympics, traffic went back up and the ER admissions for asthma went up again. But just kind of an interesting way of looking at it. Okay, so now nature prescription programs. This is something that, I think all of us should be prescribing more. And there are some really nice resources out there. There's ParkRx, there's parx.com, I think it is, or .org. You can go to these sites and actually print out scripts that you can hand to your patients. having them go into nature, because there are so many benefits of Shinrin-yoku, or what the Japanese call forest bathing. And it's now been studied actually very extensively. So not just in Japan, but in Europe, in the US, in Canada. It's been shown to lower cortisol levels, lower epinephrine, norepinephrine levels. There's improved heart rate variability, decreased systolic and diastolic blood pressure. There's boosted NK cell activity, all of these other positive effects like sleep quality and mood, just from being in nature for 20 minutes a couple times a week. So, I always tell my residents and my med students that we should be doing this ourselves more, but we should definitely be telling this to our patients. I'm just going to skip through some of this in the interest of time, but certainly happy to talk more about this later. Part of the benefit might be because of these substances, phytoncides and terpenes, which are concentrated in the bark of trees. And they seem to have all of these very positive impacts, which is not shocking because about 60% of our pharmaceuticals are either primarily or secondarily derived from plant sources. And so a lot of these effects are things like antimicrobial impacts, antispasmolytic or spasmolytic impacts, anti-nausea, anti-nociceptive, and anti-inflammatory. So there seems to be more to it than just walking and seeing nature. And as I mentioned, there are all of these plant-derived medications, and we've only interrogated maybe about 10 to 15% of terrestrial plants for their pharmaceutic potential. So, of course, we have another reason to preserve biodiversity. And in the last few minutes here, I'm going to talk about microplastics. And you might say, well, why are we talking about microplastics in a climate health talk? And the rationale is that most of these are derived from petrochemicals. And so essentially everything that is being pumped out of the ground or fracked is not good for our health. Plastics are certainly, as we know, everywhere, and they are increasing in a very intentional path made by the fossil fuel industry, because they recognize that renewable energy is becoming less expensive, and so there needs to be an output for their product. So right now, it's expected that there will be a doubling of plastics by 2040 and a tripling by 2060. If you look at bottled water, it's been estimated that there's about 10 to the fifth particles of microplastics in bottled water, and they're present in all of us. It's in breast milk, it's in placenta, urine, stool. We'll go into some of the studies that localize it in the body as well. And most of it is from disposables, as you can imagine, packaging, things like that. So we don't just get this from eating it. You might think that, oh, it's just from the seafood that we're eating. And actually the ocean probably has less contamination than the air we're breathing. There's been some really interesting studies with that. So we are inhaling these particles as well. And because it's in a lot of personal care products, it can also be absorbed through the dermis. Now, PFAS, which is just one example of the microplastics. But a lot of these microplastics act as endocrine disruptors. And so as a result, they affect us from womb to tomb, essentially. So they can have everything from adverse birth outcomes, even decreased cognition because of subtle impacts on thyroid hormone in utero, can affect low birth weight. But then you can have things like hormone-sensitive cancers being impacted, and obesity, and all of these multitudinous impacts, really. And I won't get into all of this, but there have been in the past 3 years or so some really nice review articles that have come out detailing some of those potential impacts. In their role as endocrine disruptors, they can also cause immune impairments. There have been associations with high PFAS levels and decreased antibody response. And as I mentioned, neurodevelopmental harms. It's been associated with ADHD and also decreases in IQ. Now, this is a really interesting study. People may have heard about this one. It came out a year ago and hit the press big time. So this was from Italy. They looked at people who had carotid endarterectomies, and they took those atheromas and looked to see if there were plastics in them. And for those patients who had plastics, they had a 4.5-fold increased risk of death, heart attack, or stroke. And it seems like, so you can see the arrow sign here with these little nasty microplastics. It seems like around these microplastics, there were signs of inflammation. So cytokines, interleukins, and it seems like that inflammatory milieu then made the plaque more friable, more prone to breaking off and leading to these adverse outcomes. Another study that also made a big splash in the press was this from Alexander Neihart's group, where they looked at decedents' brain, liver, and kidney tissue, and they sampled it for microplastics, and they compared it to decedents from 2016. And not only did our brain increase by 50% the amount of plastic that was in it, but it seems like the brain just concentrates plastics because the brain concentrations was up to 30 times higher than the liver and the kidneys. And in a lot of the press articles that you might see about it, they talk about an equivalence of an entire plastic spoon in our brain. I mean, it's scattered throughout our brains as these little tiny nano shards of polyethylene and other types of plastics, but polyethylene was really the most common. So you can see these like nasty little shards kind of all throughout our brains. And they looked at patients who had dementia and those who didn't have dementia. And for people who did not have dementia, they had a lower concentration. Those with dementia had up to tenfold higher concentrations of brain microplastics. Now, the authors are very careful to couch this by saying, well, that this was not a causation, and people who have dementia could have an impairment in their blood-brain barrier. They could have atrophy of brain tissue. But I also think it's not such a stretch that if you have glitter scattered throughout your brain, that you might have some cognitive impairment. So what are we going to do to counsel our patients with all of this? This also from the fossil fuel series in the New England Journal. Tracy Woodruff, who's an expert in plastics out in California, I think gave some very actionable and very reasonable things that we can be doing and we can counsel our patients on. So certainly we should be supporting things like the UN Global Plastics Treaty and working to make bans on chemicals and single-use disposables and acting within our healthcare systems. But we can also do things like consuming less meat and making sure that we're eating fresh foods and not storing it in plastic, and certainly not microwaving or heating plastic. Making sure that we're taking off shoes before we come in. Our kids should really be avoiding those synthetic turfs, and we shouldn't be leaving open water bottles on the field. So there are some very practical things. And from a work perspective, thinking about particularly our pregnant patients who might be vulnerable, but also the exposures that people could be having to various chemicals. So in terms of advocacy, there's a ton that people can do, but even starting tomorrow, I think one of the most important things is just start talking about this with patients and with colleagues because it's so important to change the social norms around climate health and around these environmental issues because there's a stigma to discussing it and referring back to the Six Americas study, we know that there is pretty much almost bipartisan support for this among a lot of groups. So we need to be talking about this more. We can certainly act within our healthcare system, within groups like MSNJ, within national groups, and one thing that I had worked on in particular was healthcare sustainability because the care that we deliver contributes to about 8.5% of U.S. greenhouse gas emissions. And so through ACP, I had called together a task force with all the major health systems across the state, and we produced this site report. It's the Sustainable Initiatives to Guide Healthcare Transformation. And we laid out these 13 different areas that healthcare systems could potentially try to act on and gave everyone very, very tangible things if they didn't know where to start that they could do day one. So I am happy to stop there and take questions if anyone has any questions. And thank you again for the opportunity.
Dr. Saseo, first I want to thank you. Your talk fulfills one of the three challenges that we have, namely to stay familiar with the underlying science and not just simply dismiss articles that have funny headlines. The second is obviously we need to counsel patients and families. And the third is that we need to remain strong public health advocates. There, the Medical Society has done good things. I remind you that last year we got a prior authorization reform. We recently had telemedicine pay parity, and just now we had approval of the step therapy resource reform, step therapy reform. So the Medical Society is your advocate in Trenton, and through the Medical Society, we can address some of the issues that you brought to your attention. I thank you. The floor is open to questions.
Dr. Robbins?
Hi, yeah, fantastic presentation. Actually, the cardiology, as you can imagine, the cardiologists are very concerned about this issue, especially after seeing that carotid article out of Italy. And actually, the American College of Cardiology has a number of excellent infographics for patient education. And so I had suggested that they develop one for plastics. And so the New Jersey chapter is interested in collaborating. So what do you think would be some next steps to really figure out what is the most important patient-facing information that we need to get out there on these microplastics for our patients?
Yeah, thank you for the question. And you know, I think it's something that we can pursue further as through the Climate Health Task Force and more broadly. You know, there are I would refer you to the Tracy Woodruff article, because depending on the patient's risk factors, I think that will dictate a lot of the recommendations. I mean, there are things that I tell all of my patients. So, you know, the black plastic, particularly bad. There was a New York Times article about, you know, getting rid of your black spatula. So it seems to be especially bad. Don't heat it, because even if the plastics are saying that they're microwave safe, they mean it's safe for the plastic, not safe for you. So, you know, so we shouldn't be heating up any of this. And I've gotten rid of all of our plastic dishes. Shouldn't be using plastic water bottles, shouldn't use plastic cutting boards, avoiding things like fast fashion, because a lot of those are made from synthetics, and then they leach out when we're washing them and they get into the environment. So many things and very many actionable things, as I mentioned, but I'll refer you back to that article. And then the other thing, in terms of infographics, I think it would definitely be something that ACP and maybe ACC and MSNJ could potentially collaborate on. Josh, yes.
Very quick question. Thank you again for this great presentation. Even for the lay people on this call, incredibly informative. Can you share, have you seen any of the health systems or large practices make or implement any of the changes that you highlighted in some of those later slides, or that you proposed in some of the earlier ones? I'm just curious whether there's
Yeah,
movement there.
yeah. So a lot of the health systems in New Jersey in particular, I've been very proud because they've been making a lot of headway. Clean Med just happened in Atlanta, Georgia, a couple weeks ago. And so that's the national meeting of healthcare without harm. And so I've been particularly impressed with many of the health systems across New Jersey being involved with the pledge, which, you know, is now defunct, the HHS pledge. The pledge morphed over into CARES now, CARES. The CARES pledge is now within Healthcare Without Harm, because many of the government staff who are working within the Office of Climate Change and Health Equity, when that office was dissolved, they were hired by Healthcare Without Harm. And so they're picking up some of those same initiatives. And many of the practices in New Jersey abide by that, and also work with Practice Green Health, which is an important collaborator in doing a lot of the nitty-gritty work with this. Because New Jersey has also adopted some of the more progressive building codes. A lot of the new buildings that are going up are going to be much more efficient, much more climate resilient than in other states. So there are certainly some things to celebrate, but of course, a lot of work to still be done. Yes, Dr. Like.
Yes, first of all, Dr. Cercio, thank you for a superb and very timely presentation. I put in a couple of notes for resources as well as something called the Tampa Declaration on Climate and Health, which I'm just wondering if that might be something that MSNJ and others might want to endorse. The National Medical Association was very involved with the development of that.
Yes.
I have a financial question to you and a legislative question. The financial question is, if a clinician is doing counseling related to this, are there billing codes under the social determinants of health, particularly if someone has chronic diseases? It's not so much SDOH screening, but more SDOH assessment, which my understanding is that one could bill for. So how do you handle this in the clinical arena?
Excellent question. My caveat is that I don't do a lot of the billing myself. Certainly, though, those Z codes should be used more robustly. But I don't know if I know as much about them as you do. I think you're much more the expert than I.
Yeah, we're all learning together on that. My other question is, has anybody developed brief legislative briefs that could educate policymakers across the political spectrum? Because I suspect much of this information is not known in general.
Yes.
So how would you
Oh,
do
yeah.
this to bring it forward?
Yes. So I work very closely with the Medical Society Consortium for Climate and Health. That's an organization which includes AMA. It includes 60 different medical societies, and we have an extensive toolkit. I chair the Climate Smart Healthcare Committee and their education committee, which works on getting this content into medical boards. But from the Climate Smart Healthcare piece, yes, we have policy briefs and other resources, and so maybe that's something that we need to talk about, especially with the bill that's been introduced. I should also mention too, I'm dropping this link in the chat. Hopefully it works for you. It's from the New England Journal. Because my colleague Alice Chen, who does a lot of climate health organizing, her husband is Vivek Murthy. She specifically called out New Jersey's prior authorization bill as something that we're doing preemptively to try to protect our patients. And I know MSNJ was so involved in that. And Dr. Poole.
Yeah. So I've noticed during my career in surgery that we've gone the operating room has gone away from maybe reusable instruments now to single-use instruments, which is probably more convenient in some sense, and also I'm sure it's more profitable for the device managers, but even manufacturers. But even simple things like, washing gowns. Is it better to wash surgical gowns and reuse them, or is it better just to use the single use? Because I don't see washed gowns anymore at all.
Absolutely, it is better to wash them. And some of this push was happening, that this move to single-use disposables was happening even before COVID, certainly. It accelerated. The Joint Commission, because a lot of the single-use disposables were really brought in because the reprocessing threshold was so high, and there was so much concern on the part of the health system that they were going to be liable for any kind of infectious complication, that really drove the initial switch. And the Joint Commission realized that they went a little too far with that. And that's partly why the Joint Commission wanted to have these mandatory sustainability standards. They weren't able to make it mandatory, but what they have now is a sustainability certificate, which I know several health systems in the state have actually been awarded. But the Joint Commission is now recognizing that they probably went too far. The other thing with the healthcare associated infections is that a single-use disposable isn't going to get rid of all of your infections, because now with modern techniques, we're asymptotically approaching zero and doing things like hand washing and appropriate patient stratification and all of these other things have much more impact than your reused device. So there is definitely a lot of opportunity to bring them back in. And there are tons of health systems that have been doing it successfully. but it does take sometimes clinicians to make that push.
Thank you. Thank you.
I know we went a few minutes over, and I really appreciate everyone hanging in there until the very end. And I will drop my email in the chat. I'm certainly happy to be a resource for anyone who has additional questions or wanted to chat more.
Thank you, Dr.
Thank you.
Saseo.